Yeah. Yeah, so welcome everyone. Thank you so much again for joining us on this. Well, I hope it's sunny where you are. It's sunny Wednesday. Um, we are gonna oh, sorry, next slide, Lindsay. Thank you. Yeah, so today we're gonna wrap up looking at some of the data that we had planned for last meeting, but we kind of fell short on time. And then we're gonna start. So today will be much more conversation focused instead of data heavy focus. So we're looking forward to that and hope you are too. And so in that conversation, we're gonna um, we're gonna talk through and reflect on finalize sort of the vision that you all indicated for this group. So thank you to everyone who completed completed that very brief survey and indicated your availability for June. Um, and then, yeah, we're going to sort of introduce this process that we'll be using at least the next couple of months to do some system mapping and discuss and really get into the nitty gritty of the medical home for children's system, given that we have so much expertise in this space. We wanted to sort of start that conversation with you all first before we dig into sort of any more data or any more sort of information gathering. Next slide. So these are just our virtual meeting guidelines. I think we all know them, but yeah, we'd love to see your faces, but we understand that is not possible. So please feel free to stay on mute unless you're speaking, just to mitigate any background noise for others. Please feel free to ask questions at any time, either raising your hand or in the chat. And then, yeah, and if you get disconnected, please rejoin us. We'll be here. Next slide. So this is our project, just sort of overall project purpose. We're trying to sort of understand the current pediatric medical home landscape in Michigan and those system gaps. We're working to identify Title V's role in advancing medical homes for children across the state. And then we'd like to select at least one pediatric medical home system that can focus Title V support within something that will be sort of talking about the next couple of meetings, which really is sort of moving beyond Title V, and given Title V has sort of has a scope of what it can and cannot work on, but given that we have a number of partners in this room that have that can take action or take on sort of pieces of what we sort of uncover with this process, we probably should be adding, but I think we wanted to at least talk about it today, but sort of talk about how each of us can sort of kind of contribute to this work and what chunks or pieces can sort of be taken and sort of the work carry on outside, that may occur outside of this Title V sort of lane, because we know that the medical home for children sort of system is much larger than just Title V. Next slide. So here just we've shown this a couple of times. I won't go through all of them, but here's just sort of a couple of examples of public health strategies that where public health may be able to find its sort of space, but we know that there's sort of multiple things at play within the system. Next slide. And here's our timeline. So thanks for sticking with us. We are at April now. It's hard to believe. So we're going to start our sort of systems conversation and doing some mapping for that today, and we'll sort of continue this discussion for the next couple of months and kind of see where we land in terms of sort of narrowing down our focus before we start talking strategies in July. These are our community agreements. I won't read through all of them, but just be open, be respectful, and actively participate to the extent that you are able. And, and then in case, we feel like the conversation is kind of going in a direction we don't want to, these were some strategies that members had indicated as to how we can sort of bring those issues up and discuss with one another, and we'll go through all of them, but they're here just as a reminder. And then yeah, and then now I think I'm turning it over to you, Lindsay. Is that correct?
Gloria, would you like to take it?
Oh,
Yes.
sorry,
Thanks, Jessica.
Yeah.
Thank you.
Yeah, so in our last meeting, we asked you all to share how you would describe a medical home to a friend. And some of the things that you shared include a coordinated and comprehensive approach, person-centered, not just a physical space, but a concept, a network where families can get all the care that they need, care that is understandable, culturally relevant, a steady presence in healthcare, and something that's easy to navigate, not super stressful to navigate. And there's also some direct quotes from you all that really stuck out, particularly a clinic that knows us and helps us get what we need, care that is accessible, friendly, and fair, a one-stop shop or a home room for care, and a primary care team that really cares about the patient. That's something that came up a lot, of that kind of sense of genuine care and empathy on the part of providers being a core piece of what a medical home is. So thank you all for sharing. I think this really helps us further understand what a medical home is and how to conceptualize that in plain language that we use every day. Next slide. So we also, at our last meeting, we reviewed a lot of data. We've got a little bit more to cover today, but with the data that we covered last time, we looked at insurance access, as well as healthcare access and utilization. And then we really dove into the National Survey of Children's Health Measures for Medical Home and its components. Some of the key disparities that you observed were based on special healthcare needs status, with children with special healthcare needs having a harder time receiving needed care in particular. You also observed disparities by race, with non-Hispanic Black children being less likely to have a personal doctor or have care coordination, despite having a higher percentage of those kids with adequate insurance. So there was some discussion around that of like, what if we're seeing this with insurance, why isn't that translating to the care that folks are getting? And then in a few instances also noted where Hispanic children were trending positively, with other groups staying more static, that particularly related to care coordination. And you all brought up a lot of really, really good questions as well. These related to things like the healthcare system, what other data might be available, what barriers are parents experiencing when trying to access a medical home for their children, as well as some questions specific to the survey tool. So our team will try and get back about some of these, particularly those survey related questions. And then as we move forward, as we get into our systems discussion, we're gonna kind of try and refer back to these to help guide where we want to dive in more. All right. And so before we start our discussion today, we want to hear from you. So if you can, in the chat, please share your name and pronouns, your role, whether that be a parent or organizational rep or both. And we're going to start today talking about some healthcare quality ratings. So we were interested to hear from you. What does quality healthcare mean to you?
Yeah, if you want to talk about quality healthcare in the chat, or you can just come off mute and share some of your ideas, that's fine too. Like, we'd welcome any sort of voice in the space. Kayla shared that quality means patient-centered and accessible care. Thank you. Quality care is receiving care from people committed to the field. Sarah sharing quality healthcare involves my provider taking my opinion seriously, involving me in decision-making about my care, following through on what they say they'll do, being accessible for follow-up questions. Thank you. Lisa shared quality healthcare means timely, accessible, quality care to support individual needs. Accessible care that provides patient and family-centered care. Thanks, Josh. Quality healthcare is accessible, patient-centered, equity healthcare without systemic racism. Quality healthcare with the most positive health outcome possible for an individual. And then having treated with respect, real partnership with your providers, being offered clear and informed options, receiving care that's accessible when and where you need it, and working with professionals who are knowledgeable and truly understand your needs. Yeah, so definitely a lot of patient-centered, being understood and heard, a lot of equity, coordination of care. Yeah, thank you. Keep putting your ideas in the chat. Thank you. Back to you, Gloria.
All right, so we're going to, yeah, as you have ideas about what quality care means, please do continue to add those into the chat. We're going to review some data in which users of Medicaid and Children's Special Health Care Services in Michigan, how parents rated the healthcare system for their children. So we're going to look at the CAHPS, and I'll describe what that acronym means in a second, look at the healthcare ratings from that, and then also a modified CAHPS survey that Children's Special Healthcare Services utilized. Next slide. Now, so first we're going to look at the recent Consumer Assessment of Healthcare Providers and Systems results. So this is specifically for child members in a Medicaid health plan or fee-for-service program. Their parents completed this on their behalf, and this was in 2024, so surveys were completed between February and May of that year. And for the purposes of today's discussion, we're going to focus mainly on the managed healthcare plan aspect, since that covers the majority of enrollees. So next slide. So the managed healthcare plans that participate in the Medicaid program include Aetna, Blue Cross Blue Shield, HAP CareSource, McLaren, Meridian, Molina, Priority Health Choice, United Healthcare, and Upper Peninsula Health Plan. And what we're going to see on the next few slides is a composite rating for all of those plans. If you're interested in looking at the results for each individual plan, we'll put that link to that report in the chat so that you can check it out if you would like to. But a higher percentage in the following slides means that there was higher approval from participants. And we can go to the next slide. Yeah, so for this survey, it asked about things like rating of your health plan, rating of all of your care, your personal doctor, specialists, how quickly you got your needed care, how well doctors communicate, customer service, things like that. And so one of the things that we see for the Medicaid managed care program is that overall there was a significant downward trend for customer service between 2023 and 2024. We also see that doctor communication was given one of the highest ratings by participants. It was around 95% for the past 3 years. And then health plan ratings and ratings for all health care were given some of the lowest ratings. So those were in the 60s to low 70%. Another piece to note is that you'll notice that the transportation percentages, there's a pretty big gap between 2022 and 2023. So there was lower response ratings for that particular piece. So that should be interpreted with caution there. And again, this is for all of the managed healthcare plans overall. If you are interested in looking at kind of how individual health care plans are doing, I'm going to put this link. It looked a little, might not have pasted correctly. Let me try that again. But there is a link in the PDF that you all were sent, and then here, let me send this again. So if you're interested in looking at this report in more detail, that's linked here. All right, and next slide. All right, so Children's Special Healthcare Services also did a similar survey where they took some of the modified some of the questions in CAHPS, and then also added the healthcare effectiveness data and information supplemental set and questions from the Children with Chronic Conditions measurement set, and surveyed parents of children with special healthcare needs, folks enrolled in that program between June and August of 2023. And so here we see, again, kind of similar to the results for the managed care plans overall, of doctor communication receiving highest rating of the care components, and then health plan receiving the lowest. And with this data in particular, we see some differences, significant differences between those children who are considered medically complex and those non-medically complex, where doctor communication, access to specialized services, and timely appointments, with parents of medically complex children rating these components higher than parents of non-medically complex children. And Lindsay, you can advance. Yeah, just to highlight that. And a note about that particular of kind of what medically complex means, that was determined by that additional question set from the Children with Chronic Conditions. This is something that may not be comparable in future years as Children with Special Healthcare Services has moved away from including that measurement set. But we wanted to include it here as in this survey round found significant differences there. All right, and next slide. So this survey also included questions on whether a child was unfairly treated based on their race. And here we see that most participants felt that their child was not treated unfairly, about 97% overall. Although we do see that parents of Black or African American enrollees felt their child was treated unfairly, significantly more than parents of white children. So we see that about 5% of parents responded in that way. All right, so now I'm going to pass it over to Lindsay, and we're going to discuss these data a little bit more.
Thanks, Gloria. So these are our 3 main questions, and these are the questions that we've been going through with each data set so far. So inviting you to consider like what disparities or gaps were raised for you. And we can always go back to any slide that you feel. There are only a few slides to sort of look at this time. So if you are interested in going back, I'm happy to do that. How did this data fit with your own experiences? And then what's sort of coming up for you, like questions that you have or what you might want to learn more about. So I'm going to start off with, and I'm going to stop sharing my screen just so we can see each other. But we can go back if someone's like, oh, I really wanted to see a slide, let me know and we can go back to that. But I just want to stop sharing just for a minute. And I would invite you to turn your cameras on if you can, because I would like to see your faces. I'm just curious, like, what is coming up for you all as you sort of took a look at sort of the rating slides, or some of the data that was shown? Anything particularly standing out to you all?
I saw, was it a low rating for transportation based off of health plan?
Yeah, so for transportation, and I can go back. Probably should have shared my screen. I just like to see you all, but yeah, it's okay. I understand. We need to sometimes take a look. So transportation, can you all see that slide right now? Are y'all looking? Transportation between medically complex and non-medically complex. There is a little bit of a difference there. And then going back here, transportation for the Medicaid managed care programs under CAHPS. And this was the one where Gloria shared that there was a low response rate here.
Yeah, so kind of taking that particularly that big jump between 2022 and 2023 with, interpreting that with caution, but there is a little bit of consistency between 2023 and 2024. That's kind of comparable to the lower ratings that we see for the ratings of the health plan and healthcare overall.
Yeah. I mean, I see that it says like ratings should be interpreted with caution due to low response rate, but just what I've seen patients complain about, they schedule a ride, they don't show up, using, going through the insurance plan to get those scheduled. It's hard to get them to answer the phone. So, sometimes it does work, sometimes it doesn't. But I mean, I would believe the rating that I see based off of what patients explain to me and complain about.
Thanks, Tia. Yeah. Are others seeing that too? That transportation seems to be a large issue. I'm seeing a lot of head nods. Anything else that's standing out to folks or aligning with what their experiences? Yeah.
Hi. One thing I thought was interesting was the rating of the personal doctor scores were much lower than their communication scores. So it's interesting to see that they feel that they're being well communicated with, but not necessarily are they having a high rating of their physicians.
Yeah, thank you for raising that. That is interesting. Maybe they like the communication, but not what they're saying. Maybe, I don't know. Yeah. Kara?
I was gonna say, I think like with me, like when I finally get in, they communicate well and but it might not be with my actual primary, whoever's available, or when I do get in, they communicate well, but it takes forever to get appointments, or you don't get in that day, like the availability is, so that's where the overall is still crappy.
Thanks for providing some context there, Kara. That's helpful. Yeah, Sarah.
I think both of these were completed while the unwinding of Medicaid after COVID was happening, and I wonder if that might relate to the decrease in customer service. I feel like a lot of people had questions about that. Maybe they were overwhelmed, or maybe it was hard to get good information, but just a thought on that one.
Yeah, potentially that external, like the context impacting. Sure.
I think it was interesting if you actually, when you click on the report and you go into these pages, that the healthcare plans, like the ratings versus customer service, it wasn't like this, there wasn't the same healthcare plan that was at the top for all of these good things. It was like back and forth, like Blue Cross might have been really great for one thing, and then the Upper Michigan, whatever that plan was higher for another. it was kind of disheartening to see that there wasn't one really good plan across the board, that it varied for every single thing, whether it's coordination of care, customer service. So when you actually look at the full data, that was something that was interesting to me.
Thanks, Vanessa. Anything else standing out or sort of aligning or not aligning with your personal experience?
I'm just wondering about the rating of health plans being so low, along with ratings of healthcare. You know, if it's not from getting care quickly or getting the needed care, is it related to reimbursement processes? I just wonder if there's any more data out there that would explain that being the lowest scores.
Related to that, there were really pretty low response rates. So, for some plans, single digits. I don't know if anybody even got to 20%. So it makes you wonder who would be more likely to respond. Is it people, maybe a bigger group of people who had something that didn't go well, and this was a chance for them to offer their opinion, whereas people were like, yeah, this is okay. Maybe they were less likely to respond. I don't know. There's a big group of people that we don't really know how they're
Good
feeling.
point.
It's hard to know what to do with this.
Yeah, this is Bob Van Howe. I sit on the community advisory committee for UPHP, which is the provider in the Upper Peninsula. So I've seen their internal numbers on how they're doing, and they tend to do better than the other health plans throughout the state, but they also face a different set of issues. For us, transportation means that it's a long ways just to see your primary care doctor, and it's a 200 or 300 mile trip to see a specialist for pediatrics. And so the access to specialty care is a huge there's huge barriers. So they face different issues based on the geography. So there is, but they do compare themselves to the other plans throughout the state, and there's a lot of variation, as you mentioned previously. So you kind of have to. Each plan faces its own different set of issues based on its population and its location.
Thank you. Yeah, that's definitely a good point. It's not all the same, especially with transportation. Any other questions that are coming up for folks about this data? You have questions about like who's filling this out, like the numbers. Those are really good questions. Okay, thank you. Let's see here. So just wanting to go back here to see if any of this spurs any additional like thoughts or questions between the complex and medically complex. All right. And we're going to go back. Okay, well, we're going to shift. If you do have any other additional questions, that's totally fine. We've taken notes in our Miro to highlight things, and we're keeping track of these questions and keeping track of the noticings that you all have, so that when we continue to talk through our systems discussion, we'll be able to bring those pieces back in. So it's not just like lost forever, just so you know that we are taking notes on these, and then it will be circled back in. But to sort of shift gears just a little bit, between the last meeting and this meeting, I had sent out a survey asking you all to share and to help us develop a practical vision for the group. We really want to like have this vision elements that sort of guide our group and act as a North Star, but are actionable and practical for the group. And so I asked you all 2 questions, and I really appreciate those of you that took the time to respond. And so the first question was, by the end of this project, by the end of September, what would success look like to you? What would be indicators of success? And so we took your responses and themed them together, and there were two main themes that came out from the responses. And the first, actually, I'm going to have a volunteer. I'm going to have you guys, I'm talked a lot, so I'm going to ask that one of you volunteer to read the very first element of success, if someone wouldn't mind inviting your voice into the space here. Can I get somebody to read the first one? A brave soul.
I could do it.
Thank you.
So prioritize goals in a clear action plan, specific and realistic goals to address prioritized system gaps, specific objectives, clear action steps, methods of tracking progress, and timelines.
Thank you very much. All right, and then one other friend to have our second goal by the end of September.
I can read it.
Thank you.
Strong relationships, strong and trusting relationships among advisory group members. We have learned from one another, shared diverse perspectives, and are willing to share resources.
Thank you, Sarah. Okay, so those are the two major themes that came up from the survey. And then there was one other question before I check in. So in 3 to 5 years, I asked you all to share, like, what would you hope success would look like based on the efforts of our group together? And so there were 3 major themes that came up from here. So I'm gonna have someone new invite your voice to the space. If you could read the first bullet point for me.
Improved access to comprehensive care, especially for children with special healthcare needs, more complex medical needs, and those living in rural areas and in historically underserved communities.
Thank you, Cressy. Okay. Bullet point number 2, someone new.
Measurable positive outcomes, improvements in child health outcomes aligned with our shared goals, including improved patient family satisfaction, health outcome metrics, and reduced health disparities.
Thank you, Josh. All right, and last one.
Expanded implementation of medical homes in regions that currently have significant barriers, including an increase in families, communities, and providers knowing what a medical home is, and the number of providers who function as a medical home.
Okay, so those are the 3 that this group shared would be really important and would be great indicators of success in 3 to 5 years if these 3 things happened. And so we're gonna launch a quick poll to see how this feels with the group. So I wanted to share the results with you. And then in the poll, I'm going to ask just sort of a little quick check-in to see how we feel about this. I know some of you may not have had a chance to take the survey, so we want to make sure that if this is sort of our idea of a vision, that we can move forward with it together and have it agreed upon. So we'll use this sort of stoplight approach. So if you feel really good with the vision and you feel like that's a good goal for our group, ready to move forward, then we'll vote for green. If you have a couple of things you want to talk about before moving forward, you'll vote for yellow. And then if you're like, whoa, like this doesn't seem realistic, we really need to like hit the brakes, then you would vote for red. So I'm going to have Gloria, if you're ready, if you could please launch the poll. And I'm going to push this back just so you can take a look at the vision for one of them. But yeah.
Sarah also dropped both in the chat too, in case folks want to look there as well.
Thank you. Thanks, Sarah. Give that 10 more seconds to get your votes in there. Most of you have done it. Thank you. Very good. All right. So we feel good about our vision. So I'm really glad to hear that. I'm glad to hear that, you know, you all feel like these, if we achieve this by the September, and if we, you know, we can sort of check back in and see how we're doing, you know, in 3 to 5 years, that those would be very good and actionable goals. So thanks for doing that. I really appreciate that. And I know this group will benefit by having that shared vision together. Okay. All right. So the next thing we're doing, we are transitioning a little bit into like trying to think about looking at systems gaps and analyzing the system of a medical home for children. And so something that we want to use that's going to guide our discussions moving forward for the next 3 months is a sort of a systems change approach. And I don't know if you all have seen this 6 conditions of systems change before through, it's called the Water of Systems Change by FSG, and that's one model of systems change that we're going to use to structure the conversations in the next few months. But could you raise your hand or let me know if you've seen this before, just so I can get a quick like visual if you have seen. Okay, thanks, Sarah. And if you haven't, that's totally okay. Just sort of wanted to get an idea if anyone had worked with this model before or seen these 6 conditions of systems change before. Okay. So basically when we're talking about system change, we're really wanting to try to identify and look at root causes that are holding a problem in place. And this particular model really talks about how there are different sorts of levels of system change that need to be attended to in order to like think about a problem and sort of work to meaningfully address a problem. And so you can see this particular model likes to use this inverted triangle, and they have different levels based on how explicit or implicit they are. So how obvious it is versus maybe things that are not so obvious. So oftentimes when we're thinking about how to really look at a problem or create some change, we often really think about things that are very obvious, like, okay, what policies could we impact? What practices can we change? Where do we put the money? Where do we put the people? And those are things that are pretty explicit, and they're all labeled as structural change here at the very top of the pyramid. And they're really important, but they're also there's just some of the 6 components that we need to consider. And so when we're all thinking about medical home for children and where the gaps are and what changes we need to make, we also need to think about those and what relationships are in place, where the power lies, who's holding the power, and then also how are we thinking about things? Like what assumptions are being made that might be contributing to the problem? How could we think about things a little bit differently and more creatively to help shift those conditions and make things better? So as we continue to talk together over the next couple of months, we're going to sort of structure these conversations, presentations, to sort of touch on the different conditions of systems change that you see here. So just to give us a little bit of a framework, so we know like what we're doing and where kind of where we're heading. Are there any questions about this particular triangle or anything I've shared? Okay. So for this next part, in order to really sort of ground us and think about moving forward with our systems discussion, we wanted to think about the core elements of a medical home. And I'm going to switch my screen just a little bit. We're going to switch over to the Miro board. And I'm wondering, are you able to see this, Miro, or is it still on the PowerPoint? You can. Okay, perfect. So here we have the core elements of Miro. And what we've done here, we've pulled from a couple different definitions of a medical home. We pulled from the Michigan Primary Care Consortium, and then the American Academy of Pediatrics definition of a medical home. And then also some other definitions and combine them together to try to think about a comprehensive list of the core elements of what really should make up a medical home. And so the elements are on the left column and the definition that goes along with it is on the right. And so we're going to talk through the different elements. I'm going to have you all help me read the definitions and then see if there's any questions or if there's anything that you feel like is missing. Like, oh, wow, this is an important piece of the medical home and it's not here and we need to have it represented in order to really engage in a discussion meaningfully over the next few months. So I'm going to see if I can maybe pick on someone to read the first one. Kayla, would you be willing to read the first element and definition for me?
Yeah, sorry if I go in and out. I've been battling a cold. So I was
Oh, no, I'm sorry. Yeah, do
no,
your best. It's okay.
totally fine. So, comprehensive care with a personal doctor or nurse. A child receives comprehensive care at a clinic from a personal doctor or nurse. The doctor leads a medical team to support ongoing care and coordinates care across the healthcare system.
Thank you, Kayla. Just want to pause there. Are there any questions or anything that about that definition or anything you feel like is missing? Yes, Sarah.
I just had a question. So does this imply that you're supposed to see the same doctor, personal doctor or nurse at every visit? Because I feel like there's some places that kind of can't do that.
Mm-hmm.
Does that mean they can't be a medical home?
That's a good question. That's not how I was interpreting this, but I'm
Okay.
curious about what other
I was
people
over
are.
interpreting it. Okay.
Yeah, Jane, I see your hand up. What do you think?
Hi, yeah, sorry I'm not on camera. I'm not feeling great today. Just as a little background, when I was at MPHI, the Region 4 Genetics Network, we had a whole training on medical home for families. And I actually met with people from North Carolina this morning because they're developing one. And one of the biggest points that they stress today in their training is that they emphasize that medical home is an approach to care. It's not one clinic or one doctor, that coordinates everything, but rather it's an approach to how you receive your care.
Thank you, Jane. Yep. Thank you. Anyone else want to add to that? Okay. All right. Can I get, let me see, who might I pick on here? Amy, can I pick on you to read the second one for me?
You could if I could see it.
Oh, no, you can't? The usual source of care,
Yeah.
this one?
Usual source of care across the lifespan. A child receives comprehensive care at a clinic from a personal, highly trained healthcare provider. The doctor leads the medical team to support ongoing and comprehensive care across the healthcare system.
Thank you, Amy.
I do not think that should say doctor, by the way.
Okay. Yeah, no, that's helpful. So what would you like it to say? What would make a better fit?
I just think you need to be mindful that, right, there could be an NP or a PA who's the primary care provider.
Okay. So we could say like the provider, the primary provider.
Yeah.
Would that fit better?
Suggestions in the chat.
Yeah.
The personal physician, physician assistant, or nurse practitioner.
Perfect. Okay, so we can make that change. So we could say the primary care providers for patients are leading the team. Thank you. Yeah, and this is perfect. If there's something missing, you're like, this isn't right, tell us so that we can add, because we want to like make sure that we're all on the same page as we're moving forward. Okay, thanks, Kayla. Clinician, okay, perfect. And we can adjust that. Yeah, go ahead.
Yeah, I just want to just kind of, I'm okay with that language change, but I do want to say that there is among the physician community through our organized groups, there is a desire to keep physician leadership in the core teams. And right now, all our PAs and nurse practitioners do need to work under delegated authority of a physician. So it's not totally inappropriate to say that you need a physician-led team, as long as it's very clear that the primary care provider could be any one of the above. It doesn't have to be a physician. At least that's the way I would look at that particular topic.
So what I'm hearing you say, Dr. Gilmer, is that like the physician-led team, and then among the team could be a primary care provider or something like that. Is that right?
That's how I would see it. Yes, that's be my personal take on it.
How does that feel with the group?
I'll just share as I'm a PA. I think it sounds great. Yeah, we have to practice in collaboration with a physician. My only curiosity would be, and I'm not sure, and this is what I brought up with my small group, is if like a PA or an MP is able to be designated the lead, or if it's not allowable, then I would just default to whatever is allowable or the requirements to be like the lead. My only curiosity is that like in some of the healthcare settings that I've worked, it just might create barrier if there's not enough availability or like the APP to physician ratio. So that's my only curiosity, but I would absolutely like default to whatever the requirement is, and then that's probably what the language should be.
Yeah, and I'd also question in our rural communities if a physician is even on site at many of these clinics.
Yeah, that's fair.
Thank you. These are great points, great conversation. Okay, so we'll make an adjustment with that one based on the discussions here. So that, and we have our team members taking notes below too. So it's being documented. So I think that's really helpful. Okay, can I have a volunteer to read number 3? Coordinated care and needed referrals.
I can read it. Coordinated care and needed referrals. A child's care plan is developed with their family and community, covering all parts of the healthcare system like specialists, hospitals, and home health services. The care plan is shared and used by all healthcare providers and community organizations.
Thoughts, questions, concerns about that one?
I wonder if there may be value in referencing that the medical home is the central point for care coordination. There are many entities now, including the health plans, who provide care coordination services. There are various targeted case management. The health departments provide care coordination. And I think it's getting confusing for families as to who is really the primary point of contact for them.
Okay. Yeah, so adding in like that the medical home is the primary point of contact, and then they'll help facilitate that coordination. Okay. Yep, sounds good. We can adjust that. Oh, sorry. Lisa, would you do me a favor and read quality and safety since I have you? Okay, I'm gonna pick on you.
Oh, no.
I gotcha.
Yes, you got me. All right.
Thanks.
Patient care meets high standards for health outcomes, safety, efficient use of resources, and effective management.
How are we feeling about this one? Head nods. Anything to add? Okay.
I do have one
Oh,
more
yes,
thing, Dan.
yes.
I apologize, and I didn't catch this earlier when we were reviewing it. But quality and safety is an ongoing process. It shouldn't just be a point in time where they check all the boxes. There should be some kind of quality improvement, quality assurance kind of thing that's on. So I might use the word ongoing in there just to kind of make it clear that they need a process in place that continues those standards over the course of time.
Thank you. I saw some head nods there. We can add that in thumbs up. Okay, yeah, we'll add that to the definition. I'm sorry, my dogs are wrestling like right under my feet. So if you hear that, I apologize. Okay, and let me see. Dr. Gilmer, if you would you read the accessible care for me?
Sure, accessible care. Care is nearby, easy to get to, and accepts the child and family's insurance. The clinic has open scheduling, extended hours, and offers multiple ways to get in touch with the providers and staff.
Okay. Thoughts? Additions?
You know, I know that there's a push to have high accessibility and extended hours and everything. There is challenges to meet that in terms of individual practices. I think adding that in may create more limitations for practices to consider becoming a medical home. Just a thought there.
Yeah, I would echo that on the extended hours. If you're in a small 2-person practice, you just can't do it. I mean, you can try to do it, but we always have people that are on call. So, people are available, but doesn't mean that the office is necessarily open.
Yeah, thank you. Yeah, there's something between like what we'd love to do, right? And then the reality. So for sure, I understand that. Oh, we did. Sorry, Jessica, we did. We skipped compassionate care. That is not cool of me, and I apologize. Okay, but I want to make sure that we don't have any other comments before I jump backwards. So I don't know why I did that. I really apologize because that's the one I think is really important. Yeah, Sarah.
Is open scheduling the new way of phrasing same-day appointments, or am I misunderstanding what open scheduling refers to?
Yeah, can someone help Sarah out and define
Yes.
open scheduling?
Yeah, I think, yes, I think that is the sentiment. When we were reviewing things, I was like, both, I'm glad folks have raised this because the open scheduling and extended hours, I was like, ooh, I don't, depending on where the clinic is and resources, etc. I was like, I don't know how realistic all of that is, but I was like, well, we'll see what the group thinks. So thank you all for your
Would you
feedback,
say
yeah.
kind of all is wrapped up into timely appointments and or advice?
Yes, I think that is a nice way to summarize that. So thank you.
Thanks, great question.
I also wonder about the value of including a reference to the family's insurance in addition to the child's. It would seem really the primary driver is the child's insurance.
Yes, thank you, Lisa, for that.
Okay, I'm gonna pick, let me see who I can pick on. Tara, would you be willing to read about compassionate care?
Sure. Can you
Thank
hear me okay?
Sure can.
Okay. Compassionate care that centers family and their culture. The family is seen as the main caregiver and support for the child, with all medical decisions made together. The family's culture, language, beliefs, and traditions are respected and valued, with genuine concern for their well-being shown.
Thank you very much. And sorry for skipping that one. That was not intentional. Thoughts, adjustments for this? Okay. All right, and then we have one more. Let me see. Can I ask, Kara, can I pick on you? Would you read payment structure?
I totally would, but I can't see it.
Oh,
I'm sorry. I'm on my
sorry,
phone.
I'm sorry. No worries. No worries. You know what? I can just read it. It's fine. Payment structure that encourages patient-centered care. Healthcare payments and incentives adequately cover the costs of delivering patient-centered medical home care. Financial rewards should be provided at the same time as patient-centered medical care adoption. thoughts? We feel okay about these with the adjustments that we've discussed?
I don't know if it's always feasible to provide the financial rewards at the same time as PCMH adoption. I don't know if that's realistic, but it may be realistic to say something to the effect of financial awards are distributed throughout the process rather than just at the end. I don't know how to word it though.
How do others feel?
I kind of felt the same way. I'm not sure if that second sentence is as necessary as just, the payments and incentives should adequately cover the costs or, provide, reasonable reimbursement to the providers or something. And that would take into account that they come in a timely fashion.
Okay, so maybe we could say like something about the timely, adequately and cover the costs, at a timely, something about it being
timely distribution of payments.
Yeah. Okay. Oh, yeah. Right. Thanks, Vanessa. Okay. Okay, so good. So what we're gonna do with this, so my team is going to clean that up. We'll have a new version to share with the group and our next meeting, and then in the follow-up materials, just so we can see the adjustments that we've made to this. But we'll use these definitions and these elements to guide the conversation, the systems level conversations going through and using it to provide like the framework and structure. Like these are the different core elements that are involved in the medical home. Is there anything here that you feel like is missing that should be really a part of a medical home, but we haven't said anything about it? Okay, well, if something comes to your mind, please speak up, or you can put it in the chat or email us later. This next piece that we're going to spend about 25 minutes on is we're going to divide up into 3 groups, and we're going to start looking at the relationships that are really important to a medical home by these different core elements. So for example, and I'll show you right here, this first element is here, the comprehensive care with personal doctor or nurse. And then there was the original definition that we had up here, just so you can get the idea. But we'll each be in 3 main groups, and we'll be tackling different components, and we'll be brainstorming who is a really critical and key partner for this particular core element. So that could be like within the medical system, like the patient themselves, who's important when we're thinking about relationships, and we're really thinking about partnerships that need to be thought of when we're thinking about this element. So I know I see some people jumping off, and that's fine. If you have to jump off, that's okay. But that's what we're going to be spending most of the next few minutes on, is really thinking about who are these key players in the system, who are the key partners and relationships that really need to be considered when we're thinking about this. And that will help us think about when we're thinking about our action planning and thinking about like, who do we need to tap into to kind of come up with change and help us. Then we'll have these partners listed. So that'd be really important. So I'm going to pause and see, are there any questions that you all have before we dive into our breakout groups? Okay. Sarah, do you have them ready for us?
Yes, ma'am, one moment.
Thank you. And we will be, so go ahead and join the groups, and we'll be in there for about 20 minutes.
Uh-oh, I seem to have popped out of my group. I think you're on mute.
I am. Are you stuck?
Yes, I popped in and then I popped right back out.
Oh no. Welcome back. Okay, I know that was fast. So we're gonna have, I know we have about 9 minutes left, and I just want to start with the first one, just to see. And what I think we'll do is we'll start with the first one together, just to see if anyone has any additional groups or people that are really key partners for this core element of the comprehensive care with a personal doctor or nurse. You can take a look, and I want to see if anyone has any additional, and add in a couple of stickies. People that they would like to add, or people that you feel like is missing. If you were going to have a meeting and you wanted to call the key players in for this comprehensive care with a personal doctor or nurse, and you have all these ideas here. So we have, you can see them. Care manager, community health worker, health educator, scheduler, payers, IT provider, pharmacies, HR leadership, policymakers, office managers.
We're missing the consumer there, I think.
Okay, and you mean the client, the child,
client.
the
It wa-
patient?
The patient or the patient's family, right?
Okay. Okay. Any other ones that you feel should be included that aren't represented? I like the pharmacy there. That's one that sometimes we don't think about. Okay. What about usual sort of care across the lifespan? So this is, they're receiving care at a clinic, practice from a highly trained healthcare provider. I'm leading a medical team to support the ongoing care across the system. So specialists, leadership team budgeting, outside partners to provide trainings for providers, and then the warming handoffs, who's handling that, like the phone, voicemail systems. Who else would be invited to this conversation?
Maybe care coordinators.
Okay. And then we'll do one more. So for this one, coordinated care and needed referrals. So the definition here, or the summary, is that child's care plan is developed with their family and community, covering all parts of the healthcare system, specialist hospitals, home health services, and it's used and shared by the providers and the community organizations. And we have people in the room. The really important partners are referral coordinators, care plan developers, community resources, skilled translators, referral pathway system, family spokesperson, community health workers, and hospital reps. Anyone else that should be a key part to this conversation? Feel tired, like this is it's lunchtime once they get out of here. Okay, so what I think we're gonna do, because we are so close to the end, we are gonna send this out in follow-up materials, and we will ask you to think about it maybe a little more. And then if there's anyone that you feel like should be on these boards that are not there, please let us know and we can add them in between the two meetings. We're also will clean up the medical home like elements with the definitions based on our conversation and send those back out again too, so you can have the updated definitions. I also wanted to say that our next meeting is on the May 28th. And so we're gonna keep talking about the system. We will provide an update on what we have done in between the two meetings for you all, so you can see the feedback that everyone's provided. And we're gonna start talking about how resource flows and policies, laws, and practices really impact the system. And just as a heads up, we're probably going to be reaching out to some of you to serve as maybe like a panelist on a panel discussion, or to do a really short presentation based on your area of expertise or personal experience. So just stay tuned for an email with a specific ask from us. Just so you know, because it's going to be framed a little bit differently the next couple of months of conversation. So just letting you know that that's coming. We also would love if you would please do the evaluation. Last time we only had like a few people complete it, and we definitely want to know how you're feeling. Like if you feel like you can share your perspectives and voice in the space, if you feel like we're listening, what we could do to improve, that would be super helpful. And let me see here. I want to put the link in the chat. Oh, thank you, Gloria. You're awesome. Gloria's on it. So the link is in the chat. If you wouldn't mind taking a couple of minutes just to fill this out, it really is helpful. And we'd love to hear how you feel like it's going. And we want to make sure that you feel like this is, something that, you feel like you're able to contribute to. So please do the evaluation. And then, contact us if you have any questions. And we really appreciate you and your time. So thank you all so much. And I don't know, Jessica, Carrie, Sarah, anything, Dr. Gilmer, anything you'd like to share?
Just thank you all for being here. We really appreciate your time and energy and expertise, and hope you have a good rest of your day and week.
All right. Bye, everyone. Have a wonderful day.